Welcome to Impact 45 for the month of February year 2026. And today we'll be talking about an assessment of the current state of health in Nigeria. And with us today is a professor of medicine, Professor Olufemi Fasanmade. He's the Dean of Faculty of Clinical Science, University of Lagos. He is a consultant endocrinologist and professor of medicine, University of Lagos. Professor Fasanmade is the unit head of endocrinology, diabetes and metabolism division of the Department of Medicine in the College of Medicine, University of Lagos and Lagos University Teaching Hospital, LUT. He has authored and co-authored 5 books and has 120 publications in peer-reviewed journals and more than 300 abstracts and posters presented locally and internationally. Join me as we welcome Professor Olufemi Fasanmade to Impact 45 for the month of February. You are welcome, sir.
Thank you very much, sir.
Let's start with Professor, with the continued exodus of our best medical talent, the jackpot phenomenon. What is the single most effective strategy you believe the government of young doctors to stay in Nigeria?
Thank you very much for having me. The best way to retain the younger doctors in Nigeria is actually economic. The second one is infrastructure. And I will explain briefly. When people are emigrating in the exodus, usually there are pull factors and there are push factors. The reasons why many people are going is actually economical, meaning that financial reasons. Many people do not have enough for their families, for their own personal upkeep, and to take care of themselves. So a situation where a person spends 6 years in medical school, for internship, 1 year for youth service, and then comes back to earn 300,000 naira is a major reason why a lot of people are emigrating. That's why I said it is economical. So people are comparing what they are earning in Nigeria to what they could have earned with the same qualification outside the country. And also, countries that are outside this continent and within this continent are attracting Nigerians to come and work with them because they have much higher pay than what Nigeria is offering them. So people are not only leaving the shores of this country to go overseas, some of them are also emigrating within the continent. To places where the pay is better, such as in some parts of Northern Africa and South. People to depart from the shores of this country to where they can get every single conceivable or infrastructure that they require to train and to manage their clients at the highest level.
Thank you, Prof. If this trend continues, is there no fire on the mountain?
Well, there is a great fire on the mountain. And what has the government done to try to limit this exodus? Well, first of all, the government has tried to increase the rate of producing these healthcare professionals, especially the doctors. So the NUC has been given more or less like an approval to double the intake of doctors to almost every medical school, so that those who are coming in to study medicine and dentistry, their numbers have been increased in all the schools. But the problem of that is that as you are increasing the number, even the infrastructure for accommodating a higher number of medical students does not immediately exist in most of these institutions. So it means that you are trying to mass produce people, and that may actually backfire because the quality of those that are coming out will be poorer. Because if you have a facility that can take 40 people and you now want to expose that facility to 80 people, it means the quality of what you are generating is going to be impaired. So that is one of the things that government has tried to do to reduce the number pay. But that industrial sector, you cannot just single out one group of workers to increase their pay without having others agitate. So I guess that one is making it a little bit difficult. So one needs to do collective bargaining, whereby you bring all the people in that sector and bargain and discuss with them so that whatever pay is made for them, other people do not feel shortchanged or left out.
Thank you, Professor Fasanmade. Do you see this as a total loss to Nigeria, or is there a way to harness the Nigeria diaspora to build capacity back home through short-term visits or telemedicine?
Yes, you are correct. When people talk about brain drain, there is actually some aspects that is actually brain gain. And professionals that we have in the country have had some foreign training at some time. Some of them have temporarily emigrated at their some are returning because they want to be with family, and some may be returning because of the harsh economic climate that they experience in the places where they have emigrated to. So that is the reason why many people are returning. And some just want to return because east or west, home is best. So some people, having attained all the heights of training, all the heights of professionalism over there, they return to the country to give back. So there is some gain there. And what we just hope is that the exodus of people that are leaving, that in a few years, some of them will come back to give back to the community that trained them.
Thank you, Prof, on that. But the majority of the people living are majorly youth that are very vibrant, and they can be used in so many areas. But the people returning are mainly people that they can hardly give long work hour compared to the
Well,
youth.
extent, you are right. But those who are returning, they are experienced hands. And it's not so much as the number of hours that they can give, but how much they can impact. So through their coming back, they are able to leverage on the fact that they can now train more people. And with the way of training now, there is so much you can do with technology. So some of them, even before they physically return, they are training their colleagues, they are mentoring their colleagues. Some of them are even hosting the younger ones from Nigeria to come to their laboratories, to come to their clinics, to their hospitals, to get high level of expertise and to return. Some of them don't even need to leave the shores of this country. They link with these people overseas, they get trained online, they get trained through the various electronic means, and then they are able to do or replicate what they have learned from the overseas to the people that are locally present. It is true that we are losing the young brains and the young minds, but many of them, they go out, they become highly skilled, highly trained, and they return to be able to do much more than they would have in their raw states, in their raw fashion. So I think it is not all lose-lose. There is some gain there because a young person leaves, he goes there, he acquires experience, he acquires expertise. Some of them come back with equipment, some of them come back with other colleagues to set up some of the fantastic centers that are gradually springing up. So if you look at the landscape in the country, many of the top hospitals are usually set up by some of these returnees or these diasporans. And you have so many examples in Lagos. the likes of Duchess Hospital, the likes of Reddington Hospital, the likes of Evercare, the likes of Uracare. There are so many of these hospitals that are set up by people who once were overseas, but they have returned home to set up shop locally.
It's not a total loss to Nigeria.
No, it's not.
Thank you. But on moral now, we are talking about the morale beyond salary. What's the state of morale among the senior consultants and professors who remain? How do they cope with the increased workload and responsibility left by the departing junior staff?
Well, the morale is quite low. And why is the morale low? The morale is low because their workload has increased. Their salaries haven't increased much. So they're having to do more. And they're having to see more number of patients with less number of hands. So it is quite frustrating for many of them, because now where they could have stayed in the hospital for 3 hours, they may have to stay for longer hours. Where before they could delegate duties, now they have to be more hands-on. Where they could have led a bigger team and run a clinic faster, now they have smaller teams. So clinics now drag on for hours and hours. Where a person could have said, okay, I'm going to do your operation next month, because of the few hands, next month becomes 3 months. The patients themselves are frustrated, they are upset. Some of them are taking it out on the doctors, some of them are attacking medical staff, some of them are vandalizing institutions because they feel that their care was either delayed, denied, or inadequate. So it is quite frustrating to the older ones. Very, very frustrating, and the morale is actually low. You're in a department, maybe you are 4 or 5 of you who are consultants, and suddenly you find out only one person is left, and that one person has to cover all the other units. So that is quite frustrating for most of the people that are left behind. And because of this higher workload, quite a number of them are suffering burnout. Some of them are suffering from depression, high blood pressure, ulcer, because of the increased workload.
Thank you, Professor Fasanmade. Let's talk on the National Health Insurance Authority now, NHIA Act. The NHIA Act was signed into law to replace the old scheme. In your assessment, has it truly moved the needles toward the universal health coverage, or is it still struggling with the same implementation and challenges?
I will say that the needle has moved, but not
Okay.
perceptibly. It has moved very, very little, because a
Okay.
major aspect of any health insurance is the amount of people that are covered and the amount of conditions that are covered. In the terms of the number of people covered, the number remains abysmally low. Nigeria still has less than 10% of their populace being covered by health insurance of any form, whether state health insurance or national health insurance. Less than 10% of Nigerians are covered. In terms of the conditions that they cover, also the number of conditions covered is relatively low. For instance, if you require major surgery, you find out that most of these surgeries are not covered. If you require heart surgery, you require brain surgery, you require some orthopedic surgery with all different types of implants that are expensive. Many times the health insurance does not cover this. Many types of cancer treatment, the health insurance does not cover this. So many of the complicated cases, the health insurance doesn't cover it. Things like renal transplant, kidney transplant, they are not covered under the health insurance. And even those that go to do their own transplant themselves overseas and they come back, most of the things that they use are not covered by the health insurance. So the major problem is the number of people that are covered and the extent or the conditions that are covered under this NHIA. Part of the reasons for this is that generally, because there are no laws to enforce you being captured, many people don't bother to get an insurance, and they don't see a reason why they should, because in the first instance they don't even have enough money to eat. So people say, if I've not even fed myself today, why am I paying some money or putting some money aside to insure myself? Let me eat first. So there is a lot of poverty. So people are not looking into the direction of voluntary registering for insurance or putting their money aside for any kind of insurance, whether public or private. So that is part of why it is very, very undersubscribed.
Thank you, Prof, for this. Then how do we increase the number of the ailment covered and the number of people in insurance scheme? There are people that are spending, because we discovered that the number of people spending out of pocket are so much. As a professor who sees the financial strain on patients daily, what is the biggest barrier to getting more Nigerians insured?
Okay, well, the biggest way to getting more Nigerians insured is to legislate, or let there be some form of either enforcement. Let me give you an example. If you want to look at the number of cars that have vehicle insurance, I'm sure for most states, especially Lagos State, the number will be over 90% of vehicles have a vehicle insurance. And that is because the police will stop you, and if you don't have an insurance, you'll be sanctioned. So everybody goes to get a vehicle insurance. But because there are no sanctions of not having yourself insured under the National Health Insurance Act, nobody bothers. So maybe what the government should do is there should be incentives for people to actually do so. Maybe, for instance, if some of the amounts that were supposed to be paid as allowances for staff, whether public or private, were channeled into the insurance, people will want to participate more. If you know that compulsorily 2% of your salary is going into insurance, people will follow the money. More people will want to be enrolled. More people will join. But when it becomes totally optional, you do find out that very few people do subscribe. So there should be a way to either incentivize people joining, or there should be a way to sanction those that do not join. And if you can get more and more people to join, it is a win-win, because you now have a wider base of more people contributing. So you'll be able to cover more conditions and more people in the population. So government needs, since we cannot force people to get insured, then government needs to make there an incentive. Public awareness campaigns, going to schools to talk about it, getting departments to run seminars on the importance of insurance, having success stories of how people who were insured were able to get reprieve for various ailments. These are different means that can help more people to come into the scheme.
Thank you, sir. But we are complaining about we don't have enough infrastructure to even cushion the people that are primarily now presently seeking medical assistance. If we increase the number of people now through the insurance, don't you think there is going to be more problem or pressure on the infrastructure we are complaining that is not enough?
Well, there will be an initial pressure on the infrastructure, but where there is sufficient number of people who are captured, it now works that, okay, now you are treating 10 people, now you are treating 100 people. But if those 100 people were giving that doctor one naira, he gets more money, and the health sector gets more money, the HMOs get more money, the federal government gets more money, and they can plow this same more money back into the system, because insurance is a game of numbers. It's actually better for a large pool of people to contribute very little than for a few to contribute plenty. So if you can get more people in, and then they are contributing smaller amounts, you find that you cover more. And I would like to give the example of the Lagos states that are doing something in that area. They have gone around to even the smallest communities to promote insurance. They have the scheme they call Ilere Eco, and they make it more accessible. They even actually go out to meet people to get them enrolled. They go through cooperatives, they go through artisans, they go to all the people. It's as if they are taking insurance to the grassroots. That is the way to go. So if we are looking at the number of people covered by insurance, I'm sure Lagos State will probably have much more than many other states of the country. So if other states can also do the same and have their own state insurance scheme, and they actually go to the local governments, they go to the wards, they go there to cover people, and more people are joining the pool of those who are contributing. With more money, the government or the community will be able to employ more doctors, get more equipment, and in the long run, it will be a win-win for both government and the governed.
Yeah, thank you, Prof, on that. Still on infrastructure in public hospital. When you walk through the walls today versus when you started your career, what is the most striking difference in infrastructure? Is it the equipment, maintenance culture, or something else entirely?
Well,
Compared
right.
to then when you started your profession.
Okay, well, I became a doctor about 39 years ago. And when I look at
Wow.
the infrastructure that is available now compared to then, infrastructure has actually increased. The challenge, however, is that quite a number of places, maintenance is not so properly done. For instance, you may have big MRIs, big CT scanners, and then there is no electricity to power those systems. Then that becomes like a white elephant where you have the big equipment, but they are not working. In many places, you have more number of theaters in most hospitals. 30, 40 years ago, Lutz had like maybe 4 theaters. Today, they have almost 20 of such theaters. But the challenge again is that you don't have electricity to power many of these. And some of the equipment that supply these theaters, many of them, when there's power outage, you have problems because either the service is delayed or the service is postponed. So there is greater infrastructure in almost every center, but the problem is maintaining them or getting power for them or getting skilled staff to man each and every one of them. So things that couldn't be done before, they are being done now. You find many hospitals are now doing kidney transplants, but the question is how many can afford this? Some hospitals, including Lut, they are doing bone marrow transplants. Again, just a few people are benefiting because the cost is phenomenal and the pressure, so many people wanting the same service, but majority of them being unable to afford it. And the personnel and the equipment or the infrastructure cannot take everybody at the same time. So these are challenges. So it's like a paradox. We have more equipment, we have more centers, we have more technology, we have more specialists, but the patients far outnumber the providers and the centers. And then power supply remains a big, big problem in 90% of institutions that are public in Nigeria.
Thank you, Prof. Are you saying that we have better infrastructures presently than the 70s, the 80s, but the number of patients has seriously increased that would undermine these infrastructures?
Yes, I'll give you an example. For instance, if you go to Lut, where I work, they have a cancer center, and that cancer center has various equipment, state-of-the-art equipment, equipment that delivers brachytherapy, equipment that delivers radiotherapy. They have AI backing of some of these equipment, and these are things that were not present in the 70s. At that time, the equipment was very crude, but now the equipment is high precision. But now those equipments that are there, you have so many patients that are waiting to be served. So sometimes it takes a week or two more than it should take before they are able to undergo these treatments. The same thing too, as I gave you the example, the theaters. There are many more theaters in Lut than there were in the 70s, but the number of patients are so many, and the number of surgeons and anesthetists are so few. So you have more pressure on the high-tech equipment, meaning that the output is much less. And the same picture shows in many, many hospitals throughout the Federation. So many patients, few providers, the equipment is overflogged or overworked. Sometimes the equipment breaks down because they have to use it day in, day out to take care of the large and teeming number of people.
Thank you, Prof. You mentioned the effect of this electric supply, power supply to these hospitals. How can we ameliorate this? Do you want to advocate for independent electricity supply to these health centers or medical centers? Do you want to government? You want to suggest that government like LUT should have their independent power generation plant?
Well, yes. And in fact, actually, a few years ago, Lut went off the national grid to generate their own power. And they generated their own power for 5 years. 5 years. At that time, I was I was the second in command in terms of the health infrastructure. The chief medical director at that time, together with the management team, of which I was part of, we explored the area of independent power, and we're generating huge amount of power that was able to cover the whole hospital. And for like 5 years, there was no power outage, and nobody had to buy diesel. Nobody had to use inverters or use batteries or anything. We were generating it, and what was used, it was a gas-powered, independent power plant. You will now ask them, why did loot stop? Well,
Exactly.
I left the management a few years ago, so I don't know why they actually stopped. But I heard that probably the costs of getting the gas was getting higher and higher, and the patients could not meet up with the payment, neither could the staff living in the quarters and the various departments that were using the power. So the cost of power from that IPP continued to go higher and higher, and they could no longer meet their obligations to the company that had the PPP with Loot. And so they discontinued the powering of Loot, and Loot had to revert to the national grid and back to generating power through NEPA or through diesel generators. But again, using Loot again as an example, quite a number of departments are now covered by solar power, which is able to take some of the pressure of using generators and using NEPA. And the government of the country has actually looked at providing some form of renewable energy through solar panels, through IPPs, and other means to alleviate the suffering of the federal teaching hospitals and the universities. And quite a number of hospitals and universities are in far level of discussions or implementation of getting clean energy, renewable energy from alternate sources apart from PHCN.
Wow, that's quite commendable. Let's go to the area of strike, industrial action by health workers. It seems to be very significant. Is I don't know from your vintage point, what is the fundamental breakdown in communication between the health unions and the government that prevent us from resolving these issues permanently?
Well, the problem is usually due to rivalry within the sector. And I'll give you an example. Now you're talking about brain drain. The highest number of people that are affected in brain drain are the doctors, the nurses, and to some extent, other healthcare professionals. Where the government tries to intervene and say, okay, let us increase the salary of doctors, other people will go up in arms against them and go on strike. When they go and increase the salaries of those ones, the doctors will protest that they must maintain parity or relativity, because in the healthcare sector, the doctors spend the highest number of years in the university, and their own requirements, their entry requirements into university are higher than any other health profession. So it is obvious that in most countries, doctors earn much more than all the other healthcare professionals. So that is one of the problems, interprofessional rivalry. And many of them are suspicious of the government because they feel that the Minister of State for Health and the Minister of Health are both doctors. So anything that the government does, they feel suspicious and they go on strike. If they hear that doctors are going to get a special allowance to prevent them from jackpying, they will go on strike immediately. That unless they too are given the same, they will not support the doctors. So what the government should do is there should be a way for collective bargaining. Get the various unions, put all of them together and address them holistically, not address one group and then wait for the other group to go on strike, then address them and then wait for the other group to go on strike. They should actually get all of them together, have like a town hall meeting, and then also appropriately determine what each group should enjoy. And if there are truly some areas where there is special challenge, if the government can provide some special allowances for that particular group, you find out that things will be better. I'll give you an example. If government, for instance, now says that any doctor that wants to serve in a rural area will get 3 times the usual pay of doctors, you will find that many doctors will remain in these rural areas. Everybody will not be rushing to the cities. But right now, the pay for a doctor in the city center and in the village is the same. So why shouldn't I come to the city where I can get my normal salary and then look for other jobs by the side, rather than be in the village where all they will do is the government work, and then maybe people will bring tubers of yam to appreciate the doctors. So those are some of the things that government needs to look at. Areas where people don't want to go, there should be differential pay. Specialties where they are threatened more than the others, there should be differential pay. And then to some extent, there should be collective bargaining to take care of the whole sector rather than select one or two groups.
Thank you, Professor Olufemi Fasanmade, to Impact 45 in the month of February 2026. Focusing on the clinical and academic side of the profession now, Prof. Nigeria faces a double burden of infectious diseases like malaria, Lassa fever, and rising non-communicable diseases like hypertension and diabetes. Which of these two keep you up at night more in terms of the future of public health? What's the vision of the public health? Which of these keep you at
Well,
night?
in the past, the challenge used to be communicable diseases, malaria, gastroenteritis, measles, chickenpox, smallpox. But gradually now we have moved to the era where you have the communicable diseases ravaging the country on one side and the non-communicable diseases ravaging the country from the other side. And this is partly because the population is getting older, partly because people are becoming more and more sedentary, people's weight is increasing, people are drinking more alcohol, they are drinking more carbonated soft drinks, they have access to cheap carbohydrates through the fast food centers. So we are having a double burden, Both of them actually keep us up. For instance, each time we say that there is a breakout of Lassa fever or breakout of
Yes.
conditions like Ebola, people are under a lot of fear, a lot of trouble, and nobody sleeps. At the same time, too, where you have a time where people are being brought into the hospital one after the other with heart attack, stroke. Again, these keep the public physician up and awake. So the issue is government and the healthcare sector needs to address both of these together because they are twin challenges. You cannot ignore one and leave the other. You need to take care of the non-communicable diseases. You also need to take care of the communicable diseases. But there is something that can unite them in the sense that there is something you can do that can take care of both groups. For instance, if there is enough public enlightenment, you can prevent both communicable diseases and non-communicable diseases. You can give people counsel on good diet, give people counsel on vaccination, give people counsel on hygiene, of health, of exercise, of a good lifestyle. And that way you cover both the communicable and the non communicable diseases through prevention, through public enlightenment, through telling people what are healthy choices that they can embark upon.
Thank you, Professor Fasamade. Now that we are on Lassa fever outbreak, between the beginning of 2026 and February 15, the country recorded 318 confirmed cases of Lassa fever and 70 deaths. What is the present state of things? What is the way forward to curb this fatality rate?
Well, unfortunately, Lassa fever is something that is almost endemic in this part of the world. And why is it so? Many of these conditions, Lassa fever, and Ebola, and some other conditions, they are due to vectors. Some of them are due to animals that people consume. Some of them are due to exposure of human beings to animals. And these are some of the problems that lead to all of these conditions. So for you to control Lassa fever, you need to go to the grassroots, go to the communities, advise people on their choices of food. Some people will eat almost anything inside the bush. Some people will say they're eating bush rats. Some people will eat anything that moves. And some of these the things that we consume bring in these diseases. In several other conditions that are similar to Lassa fever, you find rodents, rats, that even come into the house. They urinate there, they defecate there, and people get exposed to these viruses and these agents that are inside some of these rodents, which, if the health hygiene was there, public awareness was there, and proper care of waste and disposal of waste items, would have prevented a large number of these conditions. So public health has a major role to play in taming all of these conditions. Also, public awareness in the area of recognizing the symptoms very early so that epidemics can be prevented also needs to be put in place. Where early detection occurs, more lives can be saved. But where people go to several other places, but the right one, before they finally come to hospital, lives will be lost. So the government needs to make sure that there is continuous public awareness on conditions like monkeypox, Lassa fever. Well, COVID is no longer around, but those days, things like COVID and various other conditions, flu, and so on, measles. People need to know what these conditions look like at the early stages and how to quickly get help so that it doesn't go out of hand and it doesn't spread to too many people.
Thank you, Professor Fasanmade, on that. On local research, how robust is Nigerian contribution to global medical literature? Are we producing enough local research to solve local problems, or are we relying too heavily on data from the West?
Well, unfortunately, Nigeria is not contributing enough to global research. And the reason
Well,
for this is partly because we don't have the infrastructure. Where doctors and researchers are busy trying to make ends meet, they don't have enough time to even be productive. We are busy trying to overcome challenges like power supply, waste disposal, water supply. There is little energy and effort left to be able to go into productive research. So a major challenge is that we don't have the laboratories, we don't have the personnel, we don't have the equipment, and then people don't have the commitment or motivation to engage in any of this research. But when you go overseas, you find that a lot of cutting edge research is being done by Nigerians in the diaspora. And many of the inventions and things that people produce outside this country, many of them, we have Nigerians in the teams that are doing them. So it is not a matter of Nigeria not being able to do it, but it is a matter of not having the enabling environment to do so, not having the funding to do so. Because where you don't have funding for research, what research are you doing? Most of the researchers in Nigeria, they use out-of-pocket expenses to conduct their research. Most of the grants that even Nigerians are using to make headway, they are grants that are funded from overseas. Very few of these grants come from Nigeria. So we need to get more people to be involved and committed to putting aside some money. We have so many billionaires. How many of them are endowing prizes, are endowing chairs, or are providing grants for researchers? Very, very few. Rather, they will just want to make a building, build a building for a local government or build a hospital. Not much people are putting enough into research support.
Thank you, Prof, on that. Uh, let's look at the neglected tropical diseases. Are there diseases specific to certain regions of Nigeria that you feel are being neglected by policymakers, despite being a significant burden on your colleagues in those areas?
Well, there are many neglected tropical diseases, things like guinea worm, Most of the effort was carried out by foreign aid. Even things like leprosy, you find out that most of the donors, they are international NGOs. And there are many of conditions such as this, whereby funding is not available locally. It is people that show interest from outside. So there are many of these conditions, but very few of them get attention. River blindness, most of the programs, they are executed by foreign aid. So these tropical diseases, they are still with us, but we are not doing what we should do.
Yeah, thank you, Prof, on that. And we're looking at next generation of doctors being shaped presently on their curriculum. Um, Medical knowledge is advancing rapidly. How often is the medical school curriculum updated to reflect the diseases pattern you actually see in the Nigeria hospital and to incorporate new technologies?
Well, the curriculum continues to change. For instance, a few years ago, we were doing what you call the Spices program. Now we are doing the CCMUL program. So the curriculum is being updated very, very frequently. Before it was mainly didactic lectures. Now it is self-motivated teaching, student-centered teaching, and then there are several aspects that have been introduced to the curriculum, including entrepreneurship, general studies, and other things to make sure that the medical professional is well-rounded. Courses in the area of ethics, in the area of research methodology, all of these are being incorporated into the programs. So the curriculum is being updated on a regular basis, and we are at the front of cutting-edge technology in the area of teaching and also in the area of service.
Thank you, Professor Masamokide. On artificial intelligence now, the AI in medicine, AI is coming to healthcare globally. How do you see AI being integrated into the Nigerian healthcare system in the next decade, especially in area with a shortage of specialists?
Well, AI is being integrated even in Nigeria. For instance, now quite a number of hospitals, they employ digital record systems to archive the records. Some of them employ AI to read films or read results of various tests. Some of them even deploy AI to do things like simulation, things like planning for treatment for cancer, things like interpreting ECGs, X-rays, things like getting diagnosis based on what patients complain about. So AI has already found itself into medicine. Even nowadays, even when I collect a patient, I can take history from a patient, and with some of the devices on my phone, that interview with the patient can be converted to medical notes for a summary immediately with different diagnoses and everything. So AI is gradually being incorporated. Some of the things that you hear of, robotic surgery, some of the things that you see, endoscopic surgery, quite a number of them have AI backing. Many of them have facilities for machine learning, and even things like even looking at the back of the eye. AI is being integrated into it so that instead of the ophthalmologist struggling to look into the eyes, there are cameras now that they can check the back of the eye, and then they upload the information and they generate a report. So AI is coming into the healthcare sector powerfully in Nigeria, both in the public sector and in the private sector. And that is a welcome development because it is able to help to reduce the burden on doctors. So now, sometimes even the burden on patients, where they needed to come far distance, some of the patients are now consulting virtually online, sending their results, talking to their doctors, and then uploading the results, getting real-time interpretation of their results and their complaints.
Yeah, thank you, Professor Olufemi Fasanmade, on that. We want to look on privatization now. Do you see the future of quality healthcare in Nigeria lying in large private sector investment and facilities, or in a revitalized public health system? Where should a patient go for the best chance of a good outcome today?
Well, actually, both need to be done. Massive investment into private infrastructure is important. Also, pumping money into cottage hospitals, primary health care should also be done. So all three tiers of healthcare need to be addressed, both in the public sector and in the private sector. All of them need to be deployed. And I'm happy to see that quite a number of corporations are now coming into the country to deploy big hospital chains, to deploy big laboratories for diagnostics and big centers for treatment. So it is a welcome development, but one cannot replace the other. They all need to work in synergy. In all the various communities, there should still be small cottage hospitals, primary health centers. In slightly bigger communities, there still need to be the comprehensive health centers and the general hospitals. In the tertiary areas, serving the urban areas, we still need those tertiary hospitals, teaching hospitals, and we need large private practices that have a lot of deep pockets to get all the cutting edge technology so that people will have no reason to go for any care whatsoever outside the shores of the country.
Thank you, Prof, on that. Prof, given all the challenges we've discussed, what gives you hope? What is one positive trend or innovation happening in Nigerian medicine right now that deserve more attention?
Well, what gives me hope is the resilience of the doctors, especially those that are remaining. They are quite dedicated, they are very resilient, even with the large number of workload that they are still giving their best. And everybody will tell you, especially if you see a doctor from Nigeria practicing outside, they will tell you that that doctor is good. That Nigerians remain in high demand. Our training is second to none, and we know that the future is secure as long as we can retain some of these bright minds in the country and don't lose all of them. But the reason why people are looking for Nigerians to employ overseas is because the high level of professionalism, the high level of expertise and training that is available locally. So that gives me a lot of hope. The other thing that gives me hope is that some people are returning home to set up practices or to support those who are in the old practices with their own skills, with their equipment, and with their own infrastructure. So those things give me hope.
Thank you, Professor Olufemi Fasanmade. As we are coming to the conclusion of this Impact 45 for the month of February, the Nigerian healthcare has been seriously underfunded. How Nigeria healthcare has been seriously underfunded, has consistently failed to meet the 15% target for healthcare spending set in 2001 Abuja Declaration. In this year 2026 proposed healthcare budget,
Well,
it translates to roughly 10,400 per citizen, which is $6.75 cent for the entire year. How far can we go with this underfunding? And what's your best advice to the government?
well, healthcare funding in Nigeria is abysmally low, whether at the local government level, the state level, or the federal level. Healthcare is very, very poorly funded in this country. And a few decades ago, there was something that was called the Abuja Declaration, where all the governments of all the countries in Africa gathered together and they set a benchmark for how much money should be devoted to health. And they set that
15%
benchmark
of the
at
budget.
15%.
Yeah.
That benchmark was put at 15%. But since that Abuja Declaration, no government, whether of the current party in power or the previous parties in power, none of them have even reached 10%. So that is a
It's like
major,
4 to
major problem.
5%.
Yes, the current one now is about 5 points, I think maybe 5.4%. And
Yeah.
most of the past years have been between 4 to 5, 4 to 5. So we are not putting in enough money into healthcare spending. We are not. And if we are not putting enough money, then you cannot be expecting excellent results, because there is so far that $6 per person can carry you.
No, thank you. As we round up this, Professor, there is this renowned Nigerian author, Mamanda Ngozi Adichie. Her 21st month son passed away on January 6, 2026 at an hospital in Lagos. She has publicly alleged that gross medical negligence was the cause. Should we be are we talking? What should be the our response to this as a country?
Well, the response to this is, first of all, anybody that has suffered any form of medical neglect or negligence, certain or alleged, should report to the appropriate bodies. There is a tribunal under the Medical and Dental Council of Nigeria where people can take their grievances to. That is the highest level, and they are like a court. You can report any doctor for malpractice or any other person related to the healthcare sector. Then there are other bodies that you can also report to. I mean, you can report to the management of any hospital and seek redress. And you can sue a doctor or sue a hospital. So all these avenues are available in every country of the world. Unfortunately, people resort to putting the case on social media. It gives wide coverage, it
Yeah,
gives wide emotional outbursts, but that is not capable of reversing the trend or preventing such instances in the future. For instance, if you allege that a relative of yours died due to negligence, you should report the case, and that person that died should have an autopsy done so that they can actually see that, yes, from this body that we're examining, that doctor did something that was very, very wrong. He forgot a towel inside his stomach, he left his scissors there, or he did something that was wrong, or the dosage of drug given was too much. But unfortunately, in Nigeria, people just say, well, it's God's will. Somebody dies and they bury the person. When the healthcare center or the hospital says, can we do an autopsy? An average Nigerian will say, no, let the dead go and rest. There's no autopsy. And what that means is that there is no feedback, there is no sanction, and even the doctors don't learn from their mistakes. But if an autopsy is done, if the reports are shared with the family, with the doctor will know that, yes, I did wrong. And such a doctor can be prevented from doing wrong to another person by appropriate sanctions. But where you just put a case in the social media and the case is not reported officially, yes, a lot of outrage may occur and the doctor may be shamed. But at the same time, too, a doctor who is innocent can be shamed for something that he knew nothing about, or for a case that was very advanced and which he did his best for. So I believe that everybody should know their rights, and everybody that feels aggrieved should report, first of all, to the hospital, and then maybe through their lawyer or to the Medical and Dental Council of Nigeria, so that erring doctors can be sanctioned and so that people's confidence in the healthcare sector can be strengthened.
thank you for that information, Professor Olufemi Fasanmade. On the final note now, of vaccination, this case, I know you must have had many cases of snake bite. Uh, from the available data, we have 43,000 snake bite cases with 2,000 deaths annually. Should we be worried? When snake
Well,
bite is killing 2,000 people yearly in Nigeria, should we be worried?
well, we should be worried. We should be worried. And part of the reason why the numbers are so high is because a lot of the population are agrarian. So they have a lot of exposure to animals in the bush, including snakes. And unfortunately, most of the hospitals are not equipped with anti-snake venom. So we need to make sure that all the hospitals have access to such. We also need to have public enlightenment so that people will know what to do when they have been bitten by snakes. Because some people do the wrong thing. Some people go to the herbalist. Some people just tie a rope on the leg. People do all kinds of things. So we need to have people know what should be done, where people should be taken to. Hospitals need to be equipped. Healthcare professionals need to be trained, and where people are going into the farm, people should be advised to have protective equipment. In countries outside this country, in countries outside and instead of clearing the bush with their hands, you have people using tractors. So equipment is important, infrastructure is important, public awareness is also important, and people need to know what to do. First responders need to know what to do. People that get to the scene of a snake bite first need to know what to do. All of these things are very, very vital.
Thank you, Prof. But from what we have gathered now, we discovered that in most of these hospitals, the antivenom was not even available. And in a situation where it is available, the cost, they said the cost per shot is between 180,000 naira to 250,000 naira.
Yes, it is. It is something that is very, very expensive. And if you have to put anti-snake venom in every single hospital, it won't be sustainable. Within a few years, there will be fatigue because you buy this anti-snake venom, you stock it, and then nobody uses it, you discard it, you buy another one, you stock it, nobody uses it, and you dispose of it. So what needs to be done is that people need to know where they can get it, when they need to get it, rather than just doing a fire brigade approach of supply every hospital in Nigeria with anti-snake venom. Even anti-snake venom, there are different types. There are different anti-snake venom. How many are you going to stock? And how long are you going to stock it for? And how
Does it
often are you going to stock
depending, sorry, sir, is it depending on the snake, the particular snake that bites you?
it? Very true. Snake venoms, there are some that are polyvalent, meaning that they work on a broad range of snakes. There are some that are specific for some types of snake. So there are different types of anti-snake venom. And that is why it's difficult to just stock all and then be renewing it every year. The budget will be finished on anti-snake venom, and you may not see one single patient.
Thank you, Professor Olufemi Fasanmade. What will be your last word if people in authority they are listening to you and the policymaker are listening to you, the owner of private healthcare centers are listening to you? In just 1 minute, what is your parting word on Impact 45 for today?
My parting word will be that governments, employees of healthcare workers, they should take care of their staff. They should give their staff all the support that they can give. And this staff will give the best of service to the teeming population that they cater for. If people know that their pay is good enough, people know that government is watching their back and they are taking care of them. If people know that at the end of each month they can be sure of their pay without having salaries delayed, they will give their best. But where pays are epileptic or pay to one group is denied or blocked, then people will not be so committed. So I will say, take care of your doctors, take care of your healthcare professionals, and they will take care of the country. That is what I would say to both those who are in public sector and those who are in the private sector. Take care of your doctors. And to the doctors and other healthcare professionals, I will say, take care of yourself. Don't overwork. Don't get burnout. Don't kill yourself while trying to help people. One of the first things that they say when you are looking at safety is make sure that you yourself are safe first before you save others. So doctors should learn when to say enough. I think we can close the clinic for now. I think we can take the last case in theater right now. I think I've finished seeing the number of patients I can see, and we can postpone the others to another day. So healthcare professionals, take care of yourself.
Uh, Thank you so very much, Professor Olufemi Fasanmade. Thank you for coming to Impact 45 for the month of February 2026. Viewers, with that, we have come to the end of Impact 45 for the month of February, year 2026. Till we come your way in March, the last Sunday of March next. Thank you, Prof. Thank you for coming. We really appreciate you.
Thank you for having me. God bless you.